to let this drainage
just to
happen?
play off of you, and we'll get there. But if it's a vital emergency and there's nobody's schedule and you're reading the Wall Street Journal, you can keep working. You can do start to finish endodontics. It's a vital emergency. On necrotic, I wouldn't have handled it any different whether I was packed or I had holes in my schedule, because I need the patient to get serum levels of the appropriate antibiotic. And then when I have protection and I see the symptoms are decreasing because it's been a few hours, then it's time to get in there and get rid of all that necrotic tissue and get a good shape and, active irrigation and warm gutta percha and pack that thing and get it sealed. And that works.
Is it any harder to achieve, I don't know if we're going to actually, maybe I should wait and see if we talk about this, but is it harder to achieve anesthesia on a necrotic tooth versus a vital tooth, or is it about the same?
Vital cases are profoundly more difficult to anesthetize, and especially mandibular teeth as compared to maxillary teeth. So I don't know if I talk about it right now, but there's different ways we can get more profound anesthetic. Certainly we get a block. Okay, a block. This is now we're switching, so you're not confused. We're now talking about vital emergencies. Maybe
let's just wait then on that. Okay. I was just wondering if Rick going ahead and getting to length would cause that person maybe more pain, or if there was any anesthesia issue maybe that could have happened.
So you have a necrotic tooth, and it stinks when you open it up. Remember, board hard swelling, and they're in a lot of pain. Now, Ruddle goes in here. Maybe I'm the most clever endodontist in the world. Maybe I'm the most clumsy endodontist in the world. And I get it open up in the body. That gives me a vent, if you will, so it's easier to get debris to flush up and out of the tooth coronally, in the coronal direction, than if you're working in a really parallel canal and you're trying to work your way to length, either rotary or manually. So get it opened up, fine. But then when you take that file and run it down in the last 3, 4, 5 millimeters, right? 3, 4, 5 is the each third, apical third. Then when that file starts to approach length and you're up here with your ring finger and you're establishing patency and making sure the canal is nice and patent, what do you think I'm doing? I'm pushing debris in front of my file through the foramen into a riot zone. So if you think the patient came in hurting before, when they leave, they're going to have 1 + 1 is 5, because Ruddle has introduced bacteria from inside a necrotic putrescent canal out into an already inflamed active infection with no antibiotic.
Okay, so proceeding with treatment might end up causing the patient more pain when they get home and the anesthesia wears off.
Now, you said something, might. There are 1,000 ways, there's probably 3 or 4 or 5 ways to handle an emergency patient that has a necrotic tooth with board hard swelling and they're in pain. I'm not saying you can never keep that tooth closed. I have kept those teeth closed. I have done the emergency treatment just like Rick. I put a cork in the top of the tooth. The thing was, it's usually when the canal's dry. But if I see active welling up of suppuration or different exudates like vascular blood, I'm not trying to put the thumb on the top of the tooth and keep it corked. That's the cork in the bottle. So I'm not saying that you can't close these teeth, but if you want a peaceful practice, if you want a practice that is the sun rises in the east and sets in the west, if you want reproducibility over and over and over, you leave those teeth open. And for every one you close, you can be successful 3 or 4 times. And then you can have a massive flare-up. You can have much bigger swellings, and you'll be meeting your patient either at the hospital or at your office. And I'm just learning. I just learned over the years, way back 40, 50 years ago, you don't want to treat something that you never have a sense how it's going to be in its predictability. So if you're looking for predictability on necrotic cases with pain and swelling, you don't go to length until they're on blood levels of an antibiotic.
Okay, well, let's continue on with this.
That always works. This can usually be handled with a pulpotomy only. Now, if you open up the necrotic tooth and there's productive drainage, then I leave those teeth open for 2, 3, or 4 days. And I place them on an antibiotic because there's
there you
active
go.
infection. This is not the time to be
A guy in a
instrumenting
different outfit
and
says
getting
something different.
blocked
Same thing.
and doing a lot of gymnastics. Remember, you have a limited time and you want to be really, really definitive. So the pulpotomy works great and close the tooth. If it drains, leave it open and put a big cotton pellet. I even have little tear-off pads that I gave patients over decades called open tooth instructions. So they don't
Okay, we're going to take a look at that because we actually have a copy of the open tooth instructions.
As it was printed in that era.
Yes. Okay, so let me actually
there's my partner, Sean Robertson.
Oops.
Good man.
Whoops. Let me do this.
How come he's retired and I'm not? That's okay.
Okay, now I'm getting it up.
There you go. That's good size.
Okay. So the first thing you say, if it's your tooth, you explain to them that their tooth has been left open. So
I say that because I don't want them to go, he forgot to provisionalize my tooth. He forgot. Can you believe that?
So, and you explain why, that there might be some
drainage. Read that fifth word, intentionally, or whatever it is.
Intentionally. Your tooth has been left intentionally open to provide for drainage. Then you say every hour, rinse your mouth with hot salt water for 5 minutes. Every hour?
5 minutes on the hour.
Okay.
Tablespoon of salt in a glass of warm water, as warm as you can tolerate it, and do water chews.
Okay, and then you explain the cotton pellet has been left there to prevent food from going in.
But the heat, back to that, makes your blood vessels dilate. That carries in more antibiotic, which if you had them on, it'll get it in there in a bigger payload. It brings in more defense cells. Your own autoimmune system kicks in because you have vasodilatation. So the heat also can make it point and drain. So it's not abnormal for a patient to say to you, I was in a lot of pain, and then my gum got a little blister on it, and now I don't have pain, but I have this little bump. Is that okay? So that's because it fistulated. It's now draining through a perilous tract, a sinus tract, out into the mouth. So
now, what is the main argument for not leaving a tooth open? Is it because bacteria from your mouth is going to get in there? But then if you're going to come back and do treatment and clean out the canal and everything, does that maybe not something you would worry about, bacteria getting in there from your mouth?
The thing that would be interesting is to take surgeons, maybe even oral maxillofacial surgeons, although endodontists do a lot of surgery. So you could take your well-trained endodontic surgeons, you could take your maxillofacial, which the whole world thinks if it's in the mouth, it's the oral surgeon that does oral surgery. Well, they even cut a rubber dam, or you can buy these in mass. They're drains. They're called T drains. So you can have an eye drain. So just imagine an eye or a T with a top and a bottom, and they'll actually make an incision, wiggle the dam up, and open up the T part, and then the little flap stays down and comes out through the incision to intentionally and on purpose keep it open so it can keep draining. They don't want your gum tissues to start to heal. So I have put in countless drains in my life, and that was considered textbook. But if you left the tooth open, that was immoral. What's the difference? You're either draining it through the soft tissue or you're draining it through the tooth.